pattern to approach these leukodystrophies and some genetic diagnosis. So we'll see everything, we'll see all of these systematically. Now, these are five images. So most of these are T2 weighted images, and we have a flare axial image. Now, which of these you all think is a leukodystrophy? Can these people like answer on chat?
Yeah, ma'am, they can.
They can, right? Okay. So, so I'll give 2 minutes for maybe some 1 minute or so. Okay. So now in pediatric, age is very important. I think somebody said images C and D, so that's right. C and D are leukodystrophies. Now, image A is of a 5-year-old boy, and here we see the white matter. So now today we are going to concentrate only on the white matter. So here we have the white matter, which appears T2 hypointense or dark. That means it's normally myelinated. So this is a MRI of a normal child, 5-year-old. Now, as compared to image number B, here we have a child which is 5 days old. Okay, so this is and here the white matter appears T2 hyperintense. That means it's an unmyelinated white matter and which is normal at 5 day. So this is a brain, neonatal brain of a normal 5 day old baby, and here the unmyelinated white matter will appear T2 hyperintense. Also notice that plaque or the posterior limb of internal capsule shows subtle T2 hypointensity, and also the ventrolateral thalami both are showing T2 dark signal. That means that's normal myelination in a full-term baby. Now, the image number C is a 18 months old child. Now, at 18-month-old child, you expect some myelination to happen. So, when myelination happens, it will appear dark on T2 weighted images because it has fat. Now here the white matter is grayish. It's not hypo intense. So therefore this is a hypomyelinating leukodystrophy. I'll come to that later. So basically you have to first differentiate whether the myelin is normal or myelination is abnormal. So here we have the abnormality in the myelin, and the pathology is diffuse. So it's involving the subcortical white matter, the deep white matter, as well as the periventricular white matter, the posterior limb, anterior limb, as well as corpus callosum. All of these are involved. So it's a diffuse pathology. Now, this is a child, 20-month-old, image number D, and here we see a extremely bright signal involving mainly the periventricular and the deep white matter. And also there are these bands, T2 hypointense bands, which are within this abnormal white matter signal. And notice the subcortical white matter is still T2 dark, so it's normal. That means the myelination was normal, and then it's damaged or it's affected. So this is classically seen in dysmyelinating leukodystrophy, and this is a case of metachromatic leukodystrophy. And lastly, we have this 7-year-old child who was absolutely normal, and now we have these multifocal lesions, and this is a case of demyelination, so demyelinating disease. So this is the basic. So you have to understand, first thing in pediatrics is you have to look at your myelin. Now, yeah. So now normal myelination. So how does the normal myelination look? Now here we have the T1 and T2 weighted images at birth. So at birth, the neonatal brain has lot of water content. The white matter is not myelinated and the fat content is less. So the white matter will appear T1 hypointense and T2 hyperintense. There are only few structures which will be myelinated at birth. That will be posterior limb of internal capsule, the ventrolateral thalami, and posterolateral putamen, and also other structures in the posterior fossa. So here we are concentrating only at the level of basal ganglia. Now, what happens as the myelination progresses, the fat content in the white matter increases. So, as the fat content increases, the white matter signal appears hyper intense. So, now at 6 months, we see further myelination happening in here, that is the optic radiations, optic tracts. Here we have the anterior limb of internal capsule. The splenium of corpus callosum appears to be myelinated, and some of the occipital white matter also is myelinated. And what appears hyperintense on T1 weighted images will appear hypointense on T2 weighted images. However, the T2 signal lags behind T1 by at least 2 to 3 months. Hence, in first 6 months, you have to look at your T1 weighted images when you want to categorize myelination, when you want to know the age of the child. And at 1 year of age, so these are the images at 1 year of age, where on T1 weighted images at 1 year, the image would be similar to a normal adult brain. So it will be almost, it's like almost like a normal adult brain. Your entire white matter is myelinated, except some subcortical areas, subcortical white matter, which may not be completely myelinated, but usually that will be seen better on T2 weighted images. And again, the T2 weighted images, we see what is white here, it will be dark here. But however, T2 will lag behind by 2 to 3 months. Okay, now coming to some definitions, white matter disorders or leukoencephalopathies comprises of all disorders which exclusively or predominantly affect the white matter of the brain. Now, these leukoencephalopathies can be genetic or it can be acquired. So, leukoencephalopathies are divided into two types. The acquired ones are caused because of infection, vasculitis, etc., demyelination, whereas the genetic ones are called as leukodystrophies. So, leukodystrophies are genetically determined progressive disorders which are characterized by selective involvement of the cerebral white matter. Now, these again are divided into two types, the hypomyelinating and the dysmyelinating. So coming to abnormalities of myelination, so here I have drawn, these are four different images. Now, this quadrant here, we see normal myelination because the T2 weighted, the white matter on T2 appears dark. Therefore, it's normally myelinated. Now, as compared to this side here, we see the white matter appears grayish. So that means there's too little myelin which is deposited, and this is permanent. And T1 weighted image can be anything. Okay, it will depend on the amount of myelin deposited. If there is absolute no myelin deposition, then T1 will appear hypointense, and if there is some myelin present, then it will appear iso to hyperintense. However, T2 weighted images are most important to diagnose hypomyelinating leukodystrophies. Then we have the dysmyelinating leukodystrophy. Here, the myelin formed is defective and it is malformed. The white matter will appear extremely hyperintense on T2 weighted images and hypointense on T1 weighted images. And these are also usually diffuse involvement of the white matter. And demyelination is when there is loss of normally formed myelin. These lesions are usually focal, multifocal. Again, they will appear as hypointense on T1 weighted images and hyperintense on T2 weighted images. Now, so when a child comes to you, child less than 1 year, so infant, when you imagine infant on MR, you feel the myelin is less. It is either because of delayed myelination or because of hypomyelination. So what do? We follow up with MRI after 6 months. If there is progression of myelin, means the first scan was that of a delayed myelination. If there is no progression, that means it's a hypomyelinating leukodystrophy. So, coming to definition of hypomyelination, if there is no progression of myelination when two MRIs are done with 6 months apart, and the second MRI should be obtained when the child is more than 1 year of age. So, only if if this criteria fits in, you are surely calling it as hypomyelinating leukodystrophy. Or if a child comes to you for MRI after the age of 2 years, and if you see no myelin or severely deficient myelin, then you can call it hypomyelination. But ideally, we usually do we usually want, to be very sure, so we scan after 6 months, and just to note for the progression of myelin or not, because a lot of times there can be some perinatal insult which can result in delayed myelination, and the child can be better, with as the age grows. So now, as I told before, the hypomyelinating leukodystrophies are usually there is diffuse involvement. The white matter is mildly hyperintense, so it's grayish, not whitish typically. And the T1 weighted signal is variable depending upon the amount of myelin which is deposited. And the hypomyelination will be either unchanged or it will progress over time. Now, as compared to dysmyelinating leukodystrophy, here there is defective and abnormal myelin which is formed. So, the signal on T2 will be extremely hyperintense. The T1 signal will be hypointense. The lesions can be confluent or multifocal, usually confluent. They will change over time. There will be necrosis, cavitation, and in the end, there will be atrophy. So these are the examples. Now here we have a child where I have shown T1 IR image, and this is a T2 weighted image. So there is absolutely, now this child was 18 months old, and there is absolutely no myelination seen in the white matter. So on T1 weighted it's hypointense, and it's slightly hyper on T2 weighted, diffuse involvement. So it's a hypomyelinating leukodystrophy. As compared to here, we have abnormal signal which is seen only in the periventricular and deep white matter, which is appearing hypointense on T1 weighted images and extremely hyperintense on T2 weighted images. So this is a dysmyelinating leukodystrophy. Now, coming to radiological patterns. So, how do we diagnose, or how do we have an algorithm? So, we categorize them into whether the leukodystrophies is predominantly involving the frontal white matter, the parieto-occipital white matter, whether it is diffuse, whether it's involving the subcortical or the periventricular white matter. So, we divide into these five types. Now, coming to the frontal leukodystrophies. So, the prototype here is Alexander's disease, and we have also the frontal form of adrenoleukodystrophy, Aicardi-Goutières syndrome. Then parieto-occipital most commonly will be X-linked adrenoleukodystrophy, Krabbe's disease, and early onset paroxysmal disorders. Diffuse will be when there is diffuse involvement. So it's frontal plus parieto-occipital plus temporal plus the subcortical deep as well as the periventricular white matter. So diffuse cerebral involvement. So here the prototype here is vanishing white matter disease and MLC, which is megalencephalic leukodystrophy with cyst formation. So I will go through each of them, but just remember just the prototype. So it will be easier for us to understand. And remember, the end stage of almost all leukodystrophies will be diffuse white matter involvement. Now, primary subcortical, these are very rare and these are very few. So the few ones, the first three ones are the most important ones. So here we have L2 hydroxyglutaric aciduria, Kearns-Sayre syndrome, and Canavan's disease, of which the Canavan of all these three, the Canavan's is relatively common as compared to these two. And finally, we have the periventricular. So we have metachromatic leukodystrophy, Krabbe's disease, Sjogren-Larsson syndrome, and a mitochondrial disease called as LBSL, which is leukodystrophy with brainstem, spinal cord involvement, and lactate elevation. So we'll go through each of them. Now, coming to the leukodystrophy with frontal involvement. So here now, this is a 5-year-old boy who comes with macrocephaly and spasticity. So here, what do we see? We see abnormal T2 hyperintense signal involving the periventricular and the deep white matter. Notice the subcortical white matter is all spared because it's all normal myelin here. And there is frontal predominance. So frontal lobe more involved, white matter more involved compared to parieto-occipital. Then here these are the this is the post contrast scan. So here we see also on this T2 weighted image, we see this dark T2 hypointense caps. So these are called as garlands. So this is a classic sign seen in Alexander's disease when there is sparing of this. So basically, there's deposition of the rosanthal fibers along these ventricular caps, and because of that, they appear T2 hypointense, and these will show enhancement on post contrast. So this is one of the leukodystrophies where contrast is very useful, and it helps us to differentiate with other leukodystrophies. Also, notice there is involvement of the basal ganglia, the caudate, the putamen, corpus tritum. These are swollen. The thalami also show abnormal signal. There is abnormal signal involving the dentate and the peridentate region, and there is abnormal enhancement. So, there are some criteria to diagnose Alexander's disease. So, when there is white matter involvement with frontal predominance, periventricular rim of T2 hypointense signal, basal ganglia and thalamus involvement, brainstem involvement, and enhancement. Enhancement is an important criteria. Again, this is another child genetically proven to be Alexander's disease, and she presented to us very late. And here we see these cystic gliotic changes in bilateral, again with frontal predominance, and there are these. The caudate is completely atrophied. There are multiple these enhancing areas seen around the cystic areas, and also notice there is a severe atrophy of the brainstem, the cerebellum, and multiple areas of enhancement in the brainstem also. So so in the later stage, it is very difficult to identify, but this is also a genetically proven Alexander's disease. Now, another disease with frontal predominance is Aicardi-Goutières disease, or Aicardi-Goutières syndrome. So this is basically also called as pseudo torch because it mimics torch infection. And so here in this case, we have a 4-month-old child where the frontotemporal white matter is showing a lot of edema, swelling, and later on it will progress to atrophy. Like see here, there is a lot of atrophy, and these children will present with calcification and microcephaly, very similar to torch infection. However, this is a genetic disease, so it will as compare like torch is not a genetic disease, it's acquired as compared to AGS. So here this is another case of Aicardi-Goutières syndrome, and CT will demonstrate these calcifications very well. So the calcifications are punctate, they are along the lenticulostriate vessel. So most commonly basal ganglia calcification will be common. Also notice there is a lot of frontal atrophy. In children, we do not see prominence of cortical sulci. Like again, here there is frontal predominance as compared to here there's preserved volume of the cerebral parenchyma. Now, coming to leukodystrophies with posterior involvement. So, as we all know here, the prototype here is X-linked adrenoleukodystrophy. Now, there are various patterns described for X-linked adrenoleukodystrophy. So, here what do we see? There's abnormal signal involving the parieto-occipital white matter. The signal is confluent. It's also involving the splenium of corpus callosum, and there are some areas of cystic change, like on flare, there is rarification and there is cystic change. And again, another leukodystrophy where contrast is extremely useful. So here the advancing edge will show contrast enhancement. And adrenoleukodystrophy basically involves the corticospinal tracts. So always notice at the brainstem there might be involvement of the corticospinal tracts involving the pons, etc. So now the five patterns is the classic pattern is the parieto-occipital white matter involvement. Then we also have the frontal pattern, which is exactly reverse of this. The corticospinal pattern will be seen usually in older children where only the corticospinal tracts will be involved. There can be only cerebellum involvement, or there can be parieto-occipital plus the frontal white matter involvement. Now, this is a 5-year-old boy with neuroregression, dystonia, and spasticity. So, most commonly, these are the common symptoms where the child will present. The child is normal, and then he regresses, or he forgets his milestones, stops sitting, stops talking, stops walking, etc. Dystonia and spasticity. Spasticity, again, it means some central nervous system involvement or upper motor neuron lesion. Now, here, what do we see? Abnormal signal involving the parieto-occipital white matter. But notice the signal is not as fluffy as the last case. Again, there is involvement of the splenium of corpus callosum, some cystic changes. Also, there is involvement of the dorsal part of the pons, dorsal brainstem, here the dentate, peridentate region, deep cerebellar white matter, and here the CST, the corticospinal tracts are involved in the medulla. So the olivary nucleus in the medulla is involved. There is some amount of enhancement. So earlier we thought maybe this is adrenoleukodystrophy, but then this pattern was little atypical, and the genetics was suggestive of PEX6 gene mutation, or this is a paroxysomal disorder. So the paroxysomal disorders also have posterior predominance. So posterior white matter. So one differential for adrenoleukodystrophy will be paroxysomal disorders. Now coming to leukodystrophies with uh, yeah. Okay. So, yeah, now coming to another prototype, which is Krabbe's disease. Krabbe's disease also will have posterior predominance. However, it will also be periventricular. So, as we see here, the signal is in the periventricular white matter, but diffusion restriction is seen only in the posterior aspect. And Krabbe's classic finding would be small and dark thalami. Now, this is a 6-month-old child, and in 6-month-old child, you will normally not see so small and dark thalami. There's already volume loss and this abnormal white matter signal. Also, see this hyper intense signal which is going across the corticospinal tracts. Again, here we have abnormal signal in the corticospinal tract. And the classic sign for Krabbe's is the sandwich sign, where there is hyperintense signal around the involving the deep cerebellar white matter. This is the normal T2 hypointense signal of the dentate nucleus, and the hilum of the dentate will also be bright. So this is the sandwich sign, which is seen in Krabbe's disease. And also, if you notice, these optic nerves, they are very thick. Again, this is seen only in Krabbe's disease. So, when you have thick optic nerves, because of storage of because it's a lysosomal disease, and there is storage of the residual uh, content. So this causes thickening of the optic nerves, and the imaging pattern will vary depending on uh, the age of the child. So it can be early infantile, late infantile. Usually, the older kids will present with corticospinal tract involvement. Now, another important feature of Krabbe's is that they would have enhancement of the cranial nerves. Like we see here, the trigeminal nerves are enhancing. The seventh and eighth nerves also show enhancement. So again, Krabbe's will have multiple patterns. This is a very classic pattern or the early infantile pattern, and where there is involvement of the periventricular. So it is basically diffuse involvement of the cerebral white matter, cerebellar white matter, posterior limb of internal capsule, as well as the corticospinal tracts in the brainstem. Again, this is another child with Krabbe's disease. Now, this is a older child. So, this is 9-year-old child. So, in the juvenile form, usually you will see only involvement of the corticospinal tract and the posterior white matter. So, here, signal in bilateral corticospinal tracts, posterior white matter. There's absolutely no involvement of the dentate or the peridentate. So, there's no sandwich sign in the juvenile onset. And also, the thalami appear normal. Now, leukodystrophy with diffuse white matter involvement. Now, when there is diffuse white matter, that means there is no predominance, means there is no frontal parietal predominance, or there is and there is symmetrical involvement of the subcortical deep as well as the periventricular white matter, like we see here in this case. And the gray matter is absolutely normal. That means the basal ganglia, thalami, brainstem all appear normal. So, this is a case of vanishing white matter disease. Where there is extensive white matter involvement, there can be rarefication and cystic change later on, variable amount of cerebellar. So, cerebellar, again, cerebellar white matter may be involved. Volume loss usually happens later, and no gray matter involvement and no macrocephaly as compared to this case. Now, again, there is diffuse white matter involvement. Now, this child has macrocephaly. So, this is a very important clue to diagnose this leukodystrophy. Here, the white matter is swollen. There is involvement, again, diffuse involvement of the white matter. The posterior limb of internal capsule is involved. The gray matter is not involved, and there are these cystic change. So, the anterior temporal, posterior parietal, these areas will have cystic change. So, this is MLC or Megalencephalic leukoencephalopathy with subcortical cysts. So, to differentiate from vanishing white matter will not have macrocephaly, and there will be no cyst formation. Again, diffuse involvement. Now, this child is a 2-month-old child who had excessive cry and one episode of convulsions. The birth history is normal, and here we see a lot of gliosis, atrophy. The white matter is completely involved, and also there is involvement of the cortex. So there is white matter. Both are involved. The caudate is completely atrophied. There is abnormal signal in the thalamus. Same, if you notice the cerebellum, there is again involvement of the cerebellar cortex plus the deep cerebellar white matter. So when there is involvement of the supratentorial brain plus the plus the cerebellum or the posterior fossa, the deep gray nuclei, then think about molybdenum cofactor deficiency. This is a very close mimicker of HI. So the history of cried immediately at birth is extremely important. Now, coming to leukodystrophies with periventricular white matter involvement. So, here we have seen this case before. So, this is a case of metachromatic leukodystrophy. This is a lysosomal disorder which is occurs because of mutation in ARSA gene, which codes for aryl sulfatase. And because of this, we have because this enzyme is deficient, there is accumulation of sulfatides in the nerves, resulting in neuronal damage. So this is characterized by confluent periventricular white matter signal. Mainly, it starts with involvement of the cerebral hemisphere and then progresses to involve the cerebellar white matter. And typically, this will have this tigroid pattern. Why there is tigroid pattern? Because there is sparing of the perivascular myelin around the transmedullary veins. And again, this leukodystrophy, we have cranial nerve or cauda equina enhancement, like we saw in Krabbe's disease. Then again, the periventricular leukodystrophy, again, another child, 1 year old with developmental neuroregression, inability to walk. Now, here we see this leukodystrophy, which is showing restricted diffusion. So, very confluent, fluffy areas of abnormal white matter. There is diffusion restriction. The edges can show enhancement. That means it's the advancing edge. And also here we see some cystic chains, rarefication. So, and MRS will show this lactate peak at 1.3 ppm, and this is a classically a mitochondrial inborn error of metabolism, and this turned out to be IBA57 gene mutation, or basically just have to remember this is a type of mitochondrial uh, leukodystrophy. Now, this is a 1-year-old boy who presented with global developmental delay and ichthyosis. Ichthyosis is a very specific symptom or a complaint. Now, here we see the skin, it is so much dry and it's dark. So, there is hyperpigmentation, there is drying of the skin. And on MR, we see again periventricular white matter involvement. There is volume loss because along with exvasodilatation of the white matter. Exvasodilatation of both the lateral ventricles and volume loss of the white matter. Now, MRS here is extremely classical. So, on MRS, we see this large lipid peak here. So, this large lipid peak at zero point 0.9, uh, there are two peaks. So this is peak at zero point 0.9 and here we have 1.3 ppm. And remember you have to do at both 144 as well as 35 TE. And if you see this large lipid peak, you know this is Sjogren-Larsson syndrome. So this clinical feature of ichthyosis and periventricular white matter involvement and lipid peak is Sjogren-Larsson syndrome, no other differential. Now, coming to leukodystrophy with subcortical white matter involvement, as I said before, these cases are extremely rare. Involvement of only subcortical white matter with sparing of periventricular white matter. So, Kearns-Sayre syndrome is a mitochondrial disease, and usually it is associated with heart. So multiple problems. So like there can be ophthalmoplegia, heart conduction blocks, pigmentary retinopathy, etc. And again, because it's mitochondrial, there will be restricted diffusion and here abnormal signal. Again, the gray matter will also be abnormal. Now, as compared to L2 hydroxyglutaric acid urea, here again there is involvement of the subcortical white matter. The classic thing here is that the dentate nucleus is involved. So here we have the hyperintense signal in the dentate nucleus and also the basal ganglia is involved. Um, Now, again, another type of diffuse, a subcortical involvement. So, this disorder, so this is basically a 6-month-old child who comes with a large head and again GDD. So, these are diffusion weighted images, and here we have ADC patchy areas of restricted diffusion involving almost entire white matter. So, this disease actually starts with subcortical white matter and later on progresses to involve the entire white matter. There is also now these are the T1 weighted images, and here we have the T2 weighted images. So classically, here we have the involvement of the globus pallidus and the thalami. So these thalami are swollen, showing T2 hyperintense signal, and also there is involvement of the brainstem, the cerebellar white matter. So and the MRS is extremely diagnostic of this disease. So in spite of so much abnormal signal, we get this large NA peak, and this is a case of Canavan's disease. So Canavan's disease, basically there is diffuse cerebral cerebellar white matter involvement, but remember initially it will always start with subcortical white matter. There can be patchy areas of restricted diffusion. Remember, globus pallidus, thalami, brainstem, everything is involved, and MRS is diagnostic. And why do we have this NA peak? Because there is deficiency of N-acetyl aspartoacetylase enzyme that results in accumulation of Na. Hence, this is not reduced in spite of abnormality in the neurons. Now, leukodystrophy with brainstem involvement. So, there are some leukodystrophies which will involve the brainstem, like here. Now, here this child presented with intractable vomiting, and we see this area post trema, which is showing abnormal signal. So, here abnormal signal. Along with that, there is abnormality in the periventricular white matter. So, as I mentioned before, mitochondrial diseases usually most of the time will show restricted diffusion. However, at times they will not show restricted diffusion, like in this case. And this was a proven case of complex 1 deficiency. So, brainstem can be a part of mitochondrial disorder. Again, another child, when there is involvement of the spinal cord, here the posterior columns are involved, and there is involvement of the white matter here in the corona radiata, centrum semioval. There is involvement of the midbrain, periaqueductal gray matter. Also, the deep cerebellar white matter is involved. So again, another case of SERF1 mutation. So SERF1 and again a mitochondrial disease, and mitochondrial disease disorders will usually have inverted lactate peak at 1.3 ppm. Usually, the mitochondrial Lay's disease is a prototype or a phenotype of mitochondrial disease, but that will involve the gray matter or the deep gray nuclei. But when it comes to leukodystrophies, mitochondrial diseases can have only white matter involvement, like I showed the previous case, complex 1 deficiency. Here we have complex 4 deficiency, where only the white matter is involved, and also the spinal cord may be involved. Again, another mitochondrial disease, which is neurogastrointestinal encephalopathy, and this child presented with IBD, so inflammatory bowel disease, neuropathy, and we see this abnormal periventricular white matter, abnormal signal involving the brainstem as well as cerebellum, and yeah. So now leukodystrophy with posterior fossa involvement. This is a new neonatal scan. Here we see restricted diffusion involving globus pallidus, thalamus, the optic nerves and optic chiasm show restricted diffusion, and mainly it's the dorsal brainstem, the cerebellum, which is showing restricted diffusion. And on MRS, we have this inverted peak. So here MRS we take at 144 TE, inverted peak of branch chain amino acids. So this is classically a case of maple syrup urine disease. Now, in maple syrup urine disease, it's basically it happens because of deficiency of this enzyme branch chain keto acid dehydrogenase. Therefore, there is accumulation of these amino acids, that is valine, leucine, and isoleucine, and these will give rise to this inverted peak at 0.9 ppm. If it is lipid, lipid will be upright; it will not invert. And MRI is very typical. This is an intramyelinic edema, which is seen in the myelinated white matter, and the rest of the brain will also show edema. So entire this the things with the regions which are showing no restricted diffusion will also show vasogenic edema. So that's classic maple syrup urine disease. Now, coming to mimics of leukodystrophy. So when a child will present to you, they will not be like you they the clinician will not label that this is leukodystrophy. You have to diagnose it. So how will you do that? Now this is a case of a 5-year-old full-term baby, but now this year we have the history of not cried at birth. So here what do we see? These are the diffusion weighted images and T2 weighted images. We see restricted diffusion involving the almost entire cerebral hemisphere. Mainly, it is involving the subcortical and the cortical white matter. The corpus callosum is involved, thalamus, basal ganglia, and T2 weighted images show diffuse cerebral edema. The cortical sulci are absolutely not seen. There is also these areas of hemorrhage, intraventricular hemorrhage, choroid plexus hemorrhage, small hemosiderin stain. So this is a classic case of acute lobar hypoxic ischemic injury where there is involvement of the entire cerebral hemisphere. The gray matter as well as the white matter is involved, and there is diffuse cerebral edema. This history of not cried at birth is extremely important here. Again, this child comes with GDD and seizures, but he has this past history that he was a preterm and he did not cry at birth, severe birth asphyxia. Again, here we see these glioses, this eulogyric appearance of these gyri. So these are classically mushroom shaped because of lot of uh, volume loss and gliosis. Again, there is exvacuodilatation. The basal ganglia is completely atrophied. Thalami are small and atrophic, and there is paucity of white matter, volume loss with exvacuodilatation. So this is a classic case of periventricular gliosis or chronic HI, and the child is presenting late to you for MRI scan. This is a 10-month-old girl with developmental delay, ataxia, and hypotonia. Again, if you see this cortex, the cortex is lumpy, bumpy, it's very irregular, nodular, thickened cortex. It's involving the entire cerebral hemisphere. The white matter is diffusely abnormal. It's confluent, hyperintense signal involving the periventricular as well as subcortical white matter. And this cortex is called as cobblestone. Listen carefully, because it's thickened and it's nodular. And also, if you notice, these cerebellums are showing microcysts. So this is a case of congenital muscular dystrophy, and these disorders will classically have triad of cobblestone, listen carefully, abnormal white matter signal, and cerebellar cysts. So look for these patterns, and then you know this is congenital muscular dystrophy. The child will have hypotonia because the muscles are because it's a muscular dystrophy. So hypotonia is the most common symptom. Now this is again a new neonatal scan, 8-day old. Now the child is normal, full term vaginal delivery, cried at birth, and has one episodes of convulsion. Again, it's only the white matter involvement, the periventricular white matter, which is involved, and there is involvement of the corpus callosum. Some part of thalamus are also involved, and this was a case of paricovirus encephalitis. So paricovirus encephalitis, rotavirus encephalitis will all have these periventricular areas of restricted diffusion. So these are along the medullary veins. Uh, Again, a 1-year-old girl who comes with GDD and severe sensory neural hearing loss. So again, we see your abnormal confluent white matter. There is paucity of white matter, exvacuodilatation of the lateral ventricles. However, if you notice the cortex of there is microcephaly definitely, and the cortex is diffusely thickened here. So there is kind of pachygyria, listen carefully, spectrum, decreased amount of sulcation, and we also did CT scan and we saw these small punctate calcification along the periventricular white matter. So this turned out to be congenital CMV infection, and these children will have sensory neural hearing loss also. Lastly, we have this 7-year-old girl with acute onset of altered behavior, blurring of vision in the right eye, focal, multifocal lesions involving the cortex, subcortical white matter, lesion in the caudate, the basal ganglia, and there is a signal in the right optic nerve. So there is right optic neuritis. So this was the case of ADAM or demyelination. Uh, yeah, so this was the case of demyelination. So when you have involvement of optic nerve with cortex, subcortical involvement, focal, multifocal, think of demyelinating leukodystrophy. Um, Again, another mimic. So now this is very common. This is again a 5-year-old girl with ataxia. We see abnormal confluence signal involving the periventricular white matter, some patchy areas of involvement of the cerebellum, but notice these enhancement. The enhancement is so much punctate and very ill defined. Also, this child had the involvement of the spinal cord, which was a long segment. So it's longitudinally extensive transverse myelitis sort of. And this turned out to be MOG positive. So MOG related. So it's a kind of demyelinating disorder. And this is very common in children. And MOG antibodies was present in this case. So all these have to be differentiated from leukodystrophies. Now, coming to my last few slides. So, take home message. I would just want to revise what we did. So we saw leukodystrophies, we saw frontal predominance. Now, in frontal predominance, we saw Alexander's disease. Here, the clinical history important is macrocephaly, and also look for these periventricular rims, which are dark on T2 weighted images, and these will show enhancement. Then we saw Aicardi-Goutières syndrome. Aicardi-Goutières syndrome is same as pseudo-torch, is also called as pseudo-torch. So these kids will have microcephaly, they would have calcification. Usually the calcification will be present in the basal ganglia. There can be lenticulostriate calcifications, some calcifications in the parenchyma also. Again, there is involvement of the frontotemporal lobes, and initially there will be swelling, later on there will be atrophy, and there will be volume loss. And another frontal predominance, we also mentioned about the frontal type of adrenoleukodystrophy. Coming to parieto-occipital predominance, here we have the X-linked adrenoleukodystrophy. Again, a leukodystrophy where contrast is extremely important to know for the advancing age. Most commonly, it will involve the parieto-occipital white matter and involvement of the splenium of corpus callosum. Then we saw Krabbe's disease. Krabbe's will have multiple forms. So we saw infantile onset and juvenile onset. Juvenile will have more commonly involvement of the corticospinal tracts, whereas the infantile form will have diffuse involvement of the cerebral cerebellar hemisphere. Remember the sandwich sign, small dark thalami, and thick optic nerves. Then we also saw peroxisomal disorder, which can mimic adrenoleukodystrophy. However, there will the white matter will not be so confluent with as seen in adrenoleukodystrophy. Also, there will be involvement of the dorsal brainstem. Then diffuse white matter, vanishing white matter. Here there is diffuse involvement of the white matter, and there will be no macrocephaly as compared to megalencephalic leukoencephalopathy with cyst formation, where there is macrocephaly. The entire white matter appears to be swollen. There will be multiple these subcortical cysts here, and temporal lobe is the most common area where the cyst is formed, the anterior temporal poles. Then we have the Canavan's disease. Canavan's usually starts as subcortical, but it can progress to diffuse. So sometimes when you image the child, usually it will present as a diffuse white matter abnormality. Now here important is entire white matter is abnormal. Along with that, involvement of the globus pallidus, thalamus, brainstem, and MRS is diagnostic. MRS will show high Na peak. Now, molybdenum cofactor and isolated sulfide oxidase deficiency, they both are appear very similar. Here we have the involvement of the gray matter as well as the white matter. The supratentorial brain as well as the cerebellum is involved, and there is a lot of volume loss, gliosis, and atrophy. And coming to the mimic in diffuse white matter, we have the acute global HI, where there is diffuse cerebral edema. History is extremely important here, and there is involvement of the brain, the basal ganglia, thalamus, and the entire supratentorial brain. Coming to subcortical involvement, as I mentioned before, these are rare, but subcortical. So here we had this one case of Canavan's disease where it started with involvement of the subcortical white matter, and again, see there is involvement of the corpus tritum, thalamus, and also this child had a big Na peak. So that confirmed to be Canavan's. And then we have Kern-Sire, which is a mitochondrial disorder. So it will show restricted diffusion. It will have cardiac problems, conduction blocks, and ophthalmoplegia. L2-hydroxyglutaric aciduria, classic is involvement of the dentate nuclei. Periventricular prototype is MLD. We saw this tigroid pattern. And then Krabbe's is again periventricular, where you have periventricular involvement. There's small dark thalamus, plaque is also involved. And we saw Sjogren-Larsson syndrome, where the clinical picture will be of ichthyosis and a big lipid peak on MRS. Posterior fossa and brainstem involvement, we saw MSUD, which neonatal onset, and there is this intense restricted diffusion or intramyelinic edema. Also, there will be vasogenic edema and rest of the brain parenchyma. We saw a lot of mitochondrial inborn errors of metabolism, which will involve the brainstem and the posterior fossa. Like here we have the complex 1, here we have the complex 4 or SERF1 mutation, which also involve the dorsal columns in the spinal cord. Then we have a child with IBD who also had actually a mitochondrial inborn error of metabolism, so mitochondrial neurogastrointestinal syndrome, and the brainstem posterior fossa. This will Alexander will also have brainstem involvement, and there will be areas of enhancement. But remember, this will have frontal predominance in the supratentorial brain. Now, leukodystrophies with restricted diffusion, as we again I said before, MSUD. So neonatal onset. Think about MSUD when you have brainstem and posterior fossa involvement. Non-ketotic hyperglycemia. Here there will be again involvement of the brainstem and brainstem as well as corticospinal tracts, but the restricted diffusion will be much milder as compared to MSUD. Then mitochondrial, as we saw before, confluent leukodystrophy. Canavans can have these patchy areas of restricted diffusion. MLD can sometimes cause restricted diffusion, so metachromatic leukodystrophy. ALD will restrict along its advancing edge, and the same edge will also show enhancement. With enhancement, we saw cranial nerves, the Krabbe's disease, as well as the MLD will show enhancement of the cranial nerves. Then we have a renal leukodystrophy and Alexander's disease, which show enhancement, and hence contrast will be important only in these cases when we suspect this. Now, classic MRS pattern is MSUD, where you see inverted branch chain amino acid peak at 0.9 ppm at intermediate TE. Then non-ketotic hyperglycemia, you have to see the glycine peak at 3.5 ppm, and that peak will be again at 144 ppm, sorry, 144 millisecond. And so actually what happens, the computer will interpret this peak as myoinositol. But myoinositol, as we know, is seen only at 35 milliseconds and not at 144. So any peak which is seen at 3.5 ppm in a suspected case of NKH will be a glycine peak. And mitochondrial peak, we have this inverted lactate peak at 1.3 ppm. Then Sjogren-Larsson, we saw this large lipid peak at 35 milliseconds. And in Canavan's disease, we have a large Na peak. Now, large Na is also seen in Sala's disease, which is a hypomyelinating disorder, but I don't want to confuse you all. So just remember that Canavan's will have a big Na peak. Thank you so much.